Well, thank you so much for inviting me to speak. Richard Allen, Jeremy Tao, it's an honor, and I have no disclosures today. So the question one is, at what age do you surgically intervene for a congenital nasolacrimal duct obstruction? Less than 9 months, 9 to 15 months, or more than 15 months? Well, if you read the recent paper by Brian Money, you might actually think it should be around 9 months. It's perhaps a game changer in terms of a very large study. I personally will always wait till 1 year, but if a kid is going to be asleep at my hospital, if they're so severe, I'll probe them earlier in the operating room. It looks like most people are in that range, which is, I think, reassuring and I think proper. Next question. What is your primary procedure for congenital nasolacrimal duct obstruction? 1, in-office probing, 2, OR probing, 3, probing and stenting, 4, balloon dacryoplasty, and 5, other. Go ahead and answer that. I can tell you personally, I'm in the probing and stenting as a primary procedure. You can probably accuse me of being a little aggressive, but actually I feel like I have very good outcomes, and while I'm probably over-treating some people, I find that I have a significant lower reoperation rates. I have about a 95% success rate in children under 3. And I think the standard for most people is what the answer here is, which is OR probing. Any other questions? Is there a third question? All right, so I'll go on with my talk now. So I have no financial disclosures, and I'll be speaking today on the subject of Dacryocystocele and dacryocystitis, really focusing on the infants, so children under the age of 6 months. And I'm an oculoplastic surgeon who treats mostly children. 95% of my practice is treated at a children's hospital in Philadelphia. I think people are quite familiar with the idea that this patient likely has a congenital or some kind of blocked tear duct with a visible sac that's dilated below the medial canthus. And in terms of the diagnosis of a blocked tear duct, it is very common, 1 in 9 children, but most children, as we're quite aware, get better by the time they're 1. So with conservative management, we often can avoid surgery. When we think about the nasolacrimal anatomy, which I think most of us are very familiar with, I just want to remind you that the solid cord begins around the age of 12 weeks. And in some children, it doesn't make its way all the way into the nose. In fact, a very good study that was done by Cassidy in 1948 with a follow-up study in 1955 looked at 15 full stillborn infants and found that 11 out of those 15 on serial sections of their heads actually had a distal membrane covering the tear duct as it entered the nose. So it's not uncommon in my practice to meet a child who's had bilateral tearing, but the parent will say, you know what, one side opened up within days of birth. So I think this membrane being persistent is quite more common than we appreciate. And there are many variations to the malformation of the tear duct, whether it's simply membranous, bony, or even associated with the nasal anatomy. In terms of diagnosing what usually is blocking a tear duct, I think people are quite familiar with the idea that it is this persistent membrane of the valve of Hasner, or it's actually a stenosis where the tear duct itself is tighter so the tears just dribble through. This is a patient I'm following right now. So I've been gone since Tuesday, and I saw the patient a week ago who just had tearing and now has clearly dacryocystitis that we're quieting down with antibiotics. And I won't be focusing on this today. Children who are older, I'm a big fan of endo-DCR to treat this problem if they don't get better, and I have a feeling I'm going to come home and wind up operating on this child on Monday. But a mass over the tear sac in a neonate really is a different entity, one that needs to be treated with a certain sense of urgency or even emergency. A Dacryocystocele has also been referred to as an amniotocele. I've always wanted to look for ferning when I probe in the office, because when I get clear fluid, it's amniotic fluid. Or a dacryocele or a mucocele. Remember, in your tear sac, in your tear duct, you have goblet cells that make mucus, so that's what's filling up before it mixes with bacteria and turns green. And then, obviously, frank dacryocystitis. Now, the reason for concern and for the reason to maybe admit a child is that there is a greater risk for an intranasal cyst, and this is something that is simply not treated well with simple in-office probing. There's a greater risk for respiratory distress, and this should really be treated as an urgency or emergency, and always keep in mind that it might not be what you think it is. For example, this child who had been followed for tearing developed a frank orbital cellulitis requiring a DCR incision to drain what was essentially an enlarged lacrimal sac that broke into the orbit. Or this child with a congenital dacryocystosis. But when we met the child, we thought, this is a little bit more lateral than where the tear sac normally is. So we went ahead and imaged the patient, and I think people can appreciate this is not a tear sac, this is brain. And the patient underwent a combined procedure with neurosurgery, essentially to close up what was a large skull-base defect for an encephalocele, and here she is after her surgical repair. Or this patient with what I think people are comfortable as diagnosing not a dacryocystitis, but rather an infantile hemangioma, doesn't require surgery, just requires an oral beta blocker to allow for some nice cosmetic decrease in growth, and you can even choose to observe a patient like this instead. And then if you see enough children in your career, you'll likely encounter this entity. So this is a mass, once again, a little bit more lateral on the eyelid, not what you would think as being a tear sac, and it's actually quite firm. And on biopsy and excision, this patient only had a phacomatous corostoma, which is basically a dermoid of lenticular tissue, always in the infranasal quadrant before the fetal fissure closes and a little piece of lens breaks out. So while we're always trying to rule out malignancy, it really is quite a rarity. And I think people are quite familiar and comfortable with diagnosing dacryocystitis in an infant, especially if there's discharge. And the old school, the way I was trained, is to put them on IV or oral antibiotics and to bring them in the office and probe them. This is what some of my previous mentors had done. Or even another mentor liked to drain them externally with a needle to allow to decompress. And this patient ultimately needed a DCR, which I think many of them do when they're in the infant age. And I think I'm guilty of saying, well, this is what I've always done. This is what I was trained to do, without really looking. And in reality, it just took me one case 6 years into my practice to realize I was missing the boat on treating this problem. And just like swimming was ruined for me because of this movie, realizing there was an intranasal cyst really changed the way I approached things. So here's a patient I met. It was the daughter of an anesthesiologist in my hospital who had a congenital dacryocystosis, and I probed her in the office, and she immediately went into respiratory distress. She turned blue. We admitted her to the hospital. ENT went and imaged her. And I think people can appreciate on this coronal CT, very large intranasal cysts with a right dacryocystosis and a non-clinical left block tear duct, but clearly present cyst causing obstruction. Now, why do these cysts form? Well, if you can imagine, if this nasolacrimal duct is obstructed in utero, amniotic fluid is simply pressing on it, and you get this outpouching within the valve of Hasner. The dacryocystosis itself was first described in literature in 1908, and its association with intranasal cysts was appreciated as early as 1982. And a really important publication from Alex Levin when he was at Sick Children's in Toronto noticed that a good number, if not all, of patients that are infants that have dacryocystosis have intranasal cysts. These can even be diagnosed in utero. So sometimes I'll get a parent who comes to me either pregnant or with this diagnosis to say they've noticed this for a long time. A really wonderful review from Muhammad Ali in 2019 in the OPRS literature just showed how many people, I think, miss the fact that there's a cyst, because there's a range from 11 to 100% of associated intranasal cysts in the setting of dacryocystosis. And you have to remember that neonates are relatively immunocompromised. There's a major risk for infection spread. In my city, we had a kid with dacryocystitis, age 3 months, who developed meningitis. Infants are obligate nasal breathers, and prompt surgery should always be considered. So what do we do for our child? Well, the child went into respiratory distress, and we wound up taking her to the OR, and this is just showing you after we microdebrided the intranasal space of a nasolacrimal cyst on the right and left side. Greg Luter published his experience in treating patients with dacryocystitis and dacryocystosis, and also found a 100% association in patients under the age of 3 months with either dacryocystitis or dacryocystosis, and were treated successfully, 94%, for that problem with simple cyst excision. He had a second group in his study that looked at patients with persistent symptoms under the age of 6 months and found just under 50% of those patients also had intranasal cysts. And that number went down as children were older in a follow-up study. So this was a treatment paradigm shift for me, where I really felt like children who had dacryocystosis should be treated urgently in the setting of followed closely with the consider to surgery if they don't resolve. And dacryocystitis is a patient I won't let leave my office. If they're under the age of 6 months, I'm very concerned about that. Here's a patient that is clearly not doing well and was only a few days old with a very large dacryocystitis, without a dacryocystocyst on the right, but with a very large cyst on the right, and with a very large intranasal cyst associated with their dacryocystitis, treated with what is essentially about a 15-minute surgery. And here she is 1 day after surgery, 1 week, and then 1 month after surgery. So we published our experience in treating this, and we treat it with a microdebrider. And this has been a great advancement for us because we used to use alligator forceps and cut through the cyst, but now the microdebrider is a very fast and effective way for us to treat this. There's less bleeding, better control. It is a dangerous instrument, as I'll show you. And once again, I have no financial interest or association with this device. But this is just to show a video of us taking a 2.9 tri-cut blade under the inferior turbinate, angling it towards the nasolacrimal duct, so about 11 o'clock on the right side, 2 o'clock on the left side, taking care not to injure the turbinate. And then you can see, after microdebriding for maybe 5 seconds, we really get nice outflow, and that's a cure, essentially, of a dacryocystitis. We published our experience with this in the Journal of Pediatric Ophthalmology and Strabismus, where we looked at 24 patients, 1 day to 5 months of age. Interestingly, of those patients, 6 out of 7 presented with unilateral masses, but actually had 4 of them had bilateral, and they all had intranasal cysts. And of those children, the ones with dacryocystitis, only 3 didn't have intranasal cysts. 29 of them were treated, 5 we excluded. And of all the patients, only 1 failed surgery because we actually found when we put a stent in that there was severe stenosis in the patient, and the patient ultimately failed and needed a DCR. Putting a stent in may be somewhat controversial because it is a foreign body, but I treat it as a drain, so I'll leave it in for a few weeks, usually 6 weeks. So I created a pathway or a treatment protocol when I meet a child with what I think is a dacryocystocyst or dacryocystitis. If I think it's infected and the patient's under 5 months, I usually will admit the patient, start them on IV antibiotics, and consider prompt surgery if they either get worse or if they're just not getting better. If it's a unilateral dacryocystocyst, I won't usually image, although sometimes I'll get an ultrasound, and I'll usually do an in-office probing, being fully aware that this is a child that I may have to admit if they have problems breathing and then suspect that there's an intranasal cyst. I tried to use an endoscope in an office in a moving baby that's tiny, but it's really hard to do, and even my ENT colleagues flat out don't do it. If it's a bilateral dacryocystocyst, I will never probe them in the office because of that risk of respiratory distress, and I usually will admit them and take them to the OR when I can. So endoscopy is quite effective. I think it's very challenging in little kids. And the other thing is in a chronic dacryocystocyst, sometimes it's hard to see that cyst because you don't necessarily have the elevation of the inferior turbinate. So you have to look under that turbinate. I think CT and MR are modalities we're doing less and less in this setting. And once again, ultrasound is sometimes, I think, useful if you're just concerned that it may be something else. And once again, beware that if it's a bilateral dacryocystocyst, it's something I would encourage you not to probe in the office. And also beware that this device that I've talked about today is extremely dangerous. In fact, some of you may be aware of a very famous case report of a patient who was enucleated during functional endoscopic sinus surgery because they thought they got into a cystic structure when doing the ethmoidal tissue, and sure enough, they sucked out the eye. So in conclusion, most infantile cases of dacryocystitis and dacryocystocysts have intranasal cysts in children under the age of 6 months. Non-infected dacryocystocysts can be managed conservatively, but should be brought to the OR if they don't resolve. And it's very helpful if a parent can massage the tear duct and essentially decompress it through the lid. That is a very good sign. Infants with acute dacryocystitis should be managed with systemic antibiotics and prompt surgery if they fail to improve, and really beware that the fact that they may have bilateral cysts. The nasolacrimal duct cysts can also be present in pediatric blocked tear duct beyond the neonatal period, and endoscopy is a useful adjunct in older infants with severe symptoms and infants whose symptoms persist after a probing. So remember, assume there's a cyst in a small child, use an endoscope, and you may need to fracture the inferior turbinate to see the cyst. Thanks so much.